So in this presentation, I'm going to talk about understanding how non-mass feature descriptors in ultrasound that correspond to non-mass enhancement on MRI can make us perform better in second look ultrasound, particularly when the cause of the non-mass enhancement on MR is so-called ECIS. Now, I want to acknowledge Laszlo Tavares' generosity in allowing me to use this large section, thick section pathology. We know that carcinoma in situ and ductal adenocarcinoma of the breast are exceedingly heterogeneous, but the number of appearances isn't infinite, and after seeing lots of Laszlo's pictures and correlating them with what I see on ultrasound, I'm able to make some better sense out of the non-mass features on ultrasound than I can under any other system. So I think, Laszlo's classification system was designed to be used with breast imaging, and therefore it lends itself well to this. Why do we need non-mass ultrasound BI-RADS features? Well, I think Tavares' system is the best classification system for understanding the imaging features. And you have to understand, quote unquote, how in situ carcinoma or DAB spreads within the breast, and I put spreads in quotes. And we really have to link these non-mass ultrasound features with the non-mass enhancement features on MR by histology. We can't just do it by simple pattern recognition. And so we can use kind of a flight simulator approach. We can start on the really obvious cases where you say, well, gee, I can understand that without even looking at ultrasound, and apply ultrasound to the obvious features and then gradually go to more subtle cases. Now, the problem with second look ultrasound for evaluating non-mass enhancement on MRI is that the literature shows that second look ultrasound is really pretty effective in identifying mass enhancement detected by MR, but it's far less effective in identifying the cause of non-mass enhancement detected by MR. And I think the basic problem there is the MR lexicon includes categories of mass enhancement and non-mass enhancement, but the ultrasound lexicon contains feature category only for mass features. It doesn't really include non-mass feature descriptors. And so I think we have a deficiency in the ultrasound lexicon that doesn't match non-mass enhancement on MRI very well. And so basically what I'm trying to do here is, using histologic understanding of what causes non-mass enhancement, create a parallel non-mass descriptor lexicon for ultrasound that would make it easier to do second look ultrasound. Now, the disconnect is that because there are no ultrasound non-mass descriptors, really only mass descriptors, although I guess we could consider some of the associated features to be non-mass. We don't specifically think of them as that way. What we do is we describe non-mass features on MR, and then we go in the ultrasound room and we look for a mass and say, second look ultrasound doesn't work. It didn't find a mass. Well, of course it didn't find a mass. We said specifically and very specifically on MR that it's not a mass. So why would we go in a room and look for a mass and then say it doesn't work? What we specifically have to do is develop a set of non-mass features that we can look for when there's non-mass enhancement. And then we don't have to come out of the room frustrated and say, yeah, we didn't find a mass. Of course, we didn't expect to find a mass because we already said it was non-mass on MR. So to as great extent as possible, the non-mass descriptors that bridge NME on MR and non-mass descriptors on ultrasound should be based on anatomy and pathology. They can't be the dumb pattern recognition things that we tend to prefer in BI-RADS. So non-mass enhancement MR can be caused by diffuse carcinoma, such as classic pleomorphic invasive lobular carcinoma. It can be caused by benign entities such as periductal mastitis or PASH, but the most common cause is DCIS or carcinoma in situ or ductal adenocarcinoma of the breast. And therefore, we really need to think about where so-called in situ carcinoma arises, how it quote-unquote spreads, and how it affects the underlying anatomy of the breast. So breast cancer is heterogeneous, and so-called in situ carcinoma, a subset of breast cancer, is also heterogeneous. Now, the Tabar classification system, which I prefer, divides cancers into AAB, acinar adenocarcinomas of the breast, and DAB, ductal adenocarcinoma of the breast. And this is an important distinction because there is a big prognostic difference between the two. So these are in situ AABs. Are they arising from the ducts? No. They're arising from the acini of TDLUs. Unfortunately, the pathologists oftentimes cut the specimen into such tiny pieces to fit on a 1 by 1 centimeter cover slide that they may not even be able to distinguish an enlarged acinus in an AAB from enlarged ducts in a DAB. But these are all AABs. These are all carcinomas that have risen within the acini of a TDLU. Acinar adenocarcinoma of the breast, AAB. It's not really DCIS because it's not arising from the ducts. It is carcinoma in situ because it's arising in the acini of the TDLU. So it's carcinoma in situ but not DCIS. It's usually grade 1 or 2, nuclear grade 1 or 2, so it has a better prognosis, but it can be unifocal, multifocal, or even diffuse. So successful treatment still might require rather extensive surgery. Now the DAB, ductal adenocarcinoma of the breast, can be DCIS, but Laszlo has shown that it can be a duct-forming invasive carcinoma with a theory of neoductgenesis, and that it's actually a stem cell cancer that's undergone epithelial to mesenchymal transformation. And the mesenchymal stem cells form the periductal desmoplasia that creates the epigenetic milieu that facilitates invasion. You know, we rarely discover DAB early. Usually it's discovered late. Frequently a whole segment or lobe is involved by the time we discover it. And the calcifications can develop late. So even though it often presents with calcifications, that's a late development. You usually don't see linear branching calcifications in a small lesion. You usually see them in a big lesion. It's usually grade 3 and has a worse prognosis. And if it is duct-forming invasive carcinoma, it can directly invade and give lymph node metastases, and it can kill. So here we're showing a unifocal AAB. It's a single TDLU with enlarged acini. In the middle, we're showing multifocal AAB, so we have multiple enlarged acini. And on the right, we're showing DAB, which is a diffuse cancer. Diffuse in the sense that it can involve a whole segment by the time we find it, and so it can be more similar to an extent to like an invasive lobular than the typical DCIS. Now, we know that whether the acini or the ducts are enlarged, there are 4 things that contribute to them. So when it's acinar enlargement, it's usually just tumor cells within the duct lumen with maybe some necrosis or fluid within the acini. But when it's a DAB or a DCIS arising in the major ducts, there can also be periductal lymphocytic reaction, periductal desmoplasia to contribute. So when we have all 4 components contributing, we tend to have much larger ducts than we have only the first 2. And so basically, neoducts in DAB are going to tend to be pretty large. Native ducts involved are going to be pretty large. But acini that are involved are going to be smaller because they're only going to have components 1 and 2. So here we see 2 different ducts. And I've got various bracketed lines. So the aqua line is just the lumen. The green line includes the lumen and some necrosis or calcification. The yellow line includes periductal desmoplasia. And the white line includes periductal immune response or lymphocytic reaction. And so you see progressively larger ducts. Well, the truth of the matter is, on ultrasound, sometimes we don't have a resolution to distinguish the aqua line from the green line, from the yellow line, from the white line. Sometimes what we see as an enlarged duct is the necrosis or secretions, which is the aqua line, the solid components, which is the green line, the periductal desmoplasia, or even a periductal lymphocytic reaction. We can't always tell those apart. So what we see enlargement may be all 4 components contributing. So again, this is a normal duct with just usual duct hyperplasia on the side contralateral from the calcifications. Here we're showing in the rectangle exactly where the DAV specimen came from in this case. And exactly where the yellow two-headed arrow is where the maroon-colored double-headed arrow is, and that's the widest part of the duct, and that includes the four components. One is the micropapillary DAB component. Two is the secretions created by the micropapillary DAB. Three is the periductal desmoplasia, and four is the periductal lymphocytic reaction. But again, where the duct is the widest, all four components are contributing. Also notice that within the circle here we have microlobulations, and each of those microlobules corresponds to an enlarged duct filled with micropapillary DAB. Now, one thing we know is that it's much easier for us to distinguish grade 3 DAB or DCIS on ultrasound from normal ducts, because grade 3 DAB ducts can be 4, 6, 10, 8, 10 times normal size. Grade 2 DAB can be 2 to 4 times normal size, but if you take into account that duct ectasia is not uncommon, that we sometimes can't distinguish periductal loose stromal tissue from the duct itself, you know, it can be very difficult to tell a duct only 2 times normal size from normal ducts. And sometimes we can tell 4, but, you know, it's more difficult to distinguish a grade 2 DCIS or DAB duct from normal duct. And grade 1 often doesn't enlarge the duct enough for it to expand beyond the periductal loose stromal tissue, and we often can't distinguish that from normal. So our ability to see enlarged ducts caused by DCIS/DAB depends greatly on nuclear grade. We're pretty good with grade 3, intermediate with grade 2, and not so good with grade 1. Now, when we think about how carcinoma in situ spreads, here I'm showing a lesion that has 4 TDLUs and a distal end of the duct. The largest TDLU, number 1, could be where it arose, so it may have been an AAB rising in the acini of TDLU number 1, then growing down the extralobular terminal duct into the segmental duct, and then cancerizing TDLU2, TDLU3, and TDLU4. And so that's typically going to be a grade 1 or 2 because it's an AAB that it's arising from the acini. That's usually grade 1 or 2. Now, another possibility is that it started in the duct and then it cancerized all 4 TDLUs. In that case, it's going to be grade 3 because anything that starts in the duct tends to be grade 3. The third possibility is that it started everywhere at once, that it's a sick, so-called quote-unquote sick lobe. So can I tell which of the 4 situations there is here? No, I can narrow the differential. If I do a core biopsy on this and I get grade 1 or 2, it likely is an AAB that started in TDLU number 1, then cancerized the other 3 TDLUs via ductal spread. On the other hand, if I get grade 3, it probably was a DAB that started in the duct or started everywhere at once. Now, when we talk again about how cancer spreads, it can use the existing ductal system to spread itself, or it can spread via neoducts. So what I'm showing in the left upper corner here is a spread that's entirely through existing ductal system. And this could be DCIS. Doesn't necessarily have to be duct-forming invasive cancer because it's involving just the native ducts. On the other hand, it can spread entirely by neoduct formation. Now, this is going to be duct-forming invasive cancer. This is neoduct genesis. And then obviously you can have a mixture of 2. So you can have a mixture of spread through native ducts, which is usually going to be in the more central ducts, and they're going to be larger, and neoducts, which is usually going to be around the periphery of an involved segment. So this is a native duct involved with micropapillary grade 3 DAB. And notice that the caliber of the duct is variable. It's beaded, it's angular, it's irregular. There's nothing normal looking about it. Now, the ankle of the branches can vary between DCIS and DAB. So if you're involving primarily existing native ducts, your branch angles are usually going to be acute, less than 45 or 30 degrees. So what we're seeing here on the left is DCIS involving native ducts. On the right, we're showing neoducts. So here what we're seeing is that these neoducts are too numerous, and they're all coming off at near 90-degree angles. So a final thing that can help us distinguish between DCIS and neoducts is the number of ducts. If you have DCIS and it's involving only native ducts, you're going to have a normal number of ducts. But if it's neoducts, if this is a duct-forming invasive cancer, a stem cell cancer undergoing EMT, spreading itself by creating whole new ducts, if you do split-screen mirror image scans of the right and left side, you're going to see far too numerous ducts on the side with the DAB as compared to the normal side. So here's a nice Tabar 3D picture with a leading edge between neoducts on the left and normal ducts on the right. And if I look at the size of this normal duct, it's 20 pixels wide. But these neoducts, here's one that's 119 pixels wide, so it's about 6 times normal size. Here's one that's about 3 times normal size, and here's one that's about 2 times normal size. So we can see that these neoducts are grossly enlarged compared to normal ducts, but they're highly polymorphic. What does polymorphic mean? They vary greatly in size, shape, and orientation. There's nothing homogeneous about them. And this shows the polymorphism of these ducts. Now, when we look at MRI, what we're going to see is a ring enhancement pattern because we're going to get abnormal periductal and stromal neovascularity. The vessels are going to be abnormally leaky, and the contrast is going to leak out in the periductal and stromal areas. These ducts are large enough and often have enough necrosis or secretions within the lumen that we mostly just get clustered ring enhancement with them. How big can DAB-filled native ducts be, or DCIS-filled native ducts be? They can be quite large. So when I take this ruler, this millimeter ruler of Hallazgos, and I just paste that over these ducts, we can see that these enlarged native ducts are somewhere in the range of 2 to 3 millimeters. Now, they also have some blood in the lumen that is contributing to the degree of distension, but in general, involved native ducts are going to be somewhat bigger than neoducts. And here's a case with ultrasound. We can see that I've got 63 pixels, 3.8 millimeter native duct. And if I look at what a normal duct is, 12 pixels wide, my ratio is 5.3 to 1. So this duct is between 5 and 6 times the size of normal ducts. And this is another involved native duct. Again, this is 70 pixels with normal duct only 27 pixels. So we got a 2.5 millimeter involved native duct that has a ratio of almost 8 times the size of normal ducts. So this is not subtle. These are grossly enlarged ducts and enlarged native ducts. Now this is an area of a DAB that's mostly neoducts. So again, what I'm going to do is take the ruler from the bottom and I'm just going to paste it up side by side to these ducts. And we're going to see that they range in size from, say, 1.5 to 2 millimeters. So not quite as large as native ducts. The biggest of these neoducts is going to be 1.5 to 2 millimeters, whereas the biggest native ducts were 2 to 3 millimeters in size. Again, notice how heterogeneous they are. They're polymorphic. They're not normal. And when we look at that, we can see that the largest duct that I can find here is 36 pixels compared to 21.7 pixels for a normal duct. So the ratio here is about 4 to 1 instead of 6 or 8 to 1. So neoducts tend not to be as large as native ducts. Now these are AABs. So this is 2 different TDLUs filled with grade 1 to 2. This is actually grade 1 AAB. And each of these purple circles is an acinus filled with in situ carcinoma. So these are carcinoma. This is a carcinoma in situ. Now, a millimeter here is 195 pixels. And we can see that the largest acinus that I can see is 135 millimeters. So it's less than the millimeter. So we're seeing that when I have AAB, the enlarged acini tend to be less large than the neoducts from a DAB. Now this is grade 1, and we're seeing 0.5 millimeter to 1 millimeter size of these enlarged TDLUs. But here's a grade 2 with some necrosis and calcifications. This would give us the crushed stone calcifications that Laszlo talked about. So again, my millimeter marker is 161 pixels. I can see that I've got 166 pixels in this duct filled with secretions or necrosis, and here I can say that it's a little smaller. It's about 0.8 of a millimeter, but have some calcifications there. So, you know, the enlarged acini can range from 0.5 millimeters to about a millimeter, certainly smaller than neoducts. Now, part of the reason that pathologists get confused between DCIS and CIS, or between enlarged acini and enlarged ducts, is because they chop the specimen up into little bitty pieces that fit under a 1 by 1 millimeter cover slide. So what we're seeing here is this normal duct is 52 pixels wide, and the largest acinus is 83 pixels wide, which is 1.6 millimeters. So if you don't have a big, large section, it can be very difficult for the pathologist to determine whether this is an enlarged duct or simply an enlarged acinus. And that's where the confusion on carcinoma in situ versus DCIS comes from, or AAB versus DAB. Again, this is showing what might be on a 1 on 1 by millimeter slide. If all you're seeing is enlarged acini and you have no frame of reference, you don't know whether you're dealing with a duct or an acinus. Again, notice the polymorphism. The acini vary in greatly size, shape, and location. But since they're smaller, they're more likely to present as clumped enhancement rather than clustered ring. So when we do see non-mass enhancement on MR, the AAB is more likely to show up as a clumped rather than clustered ring, simply because of small size. All right, when we look at what causes microlobulation on ultrasound, this is heavily microlobulated externally, and it's also heavily microlobulated internally. And we can see that some of the internal microlobulations are caused by pink structures that are very well circumscribed. These are neoducts filled with comedo DCIS, or they could even be enlarged acini filled with necrosis, whereas the less well-defined purple structures are cancerized lobules. So what we can see is a combination of neoducts or enlarged acini and cancerized TDLUs. Now, when we see calcifications in the ACR BI-RADS ultrasound lexicon, they can be microcalcifications inside a mass or outside a mass. And when they're inside a mass, they can just be either amorphous, or you can specifically try to place them inside of microlobulations, because we know the subgross morphology is that each of these microlobules represents an enlarged acinus or an enlarged duct. And so basically, if you get a calcification in the center of a microlobulation, it increases the positive predictive value that this is either an AAB or DAB with clustered neoducts. And again, when we see calcifications outside a mass, we want to specifically place them inside a duct. So if it's in a duct toward the nipple, these snakeskin-like calcifications are very typical of micropapillary DAB grade 3, or you can see them into smaller, more peripheral ducts. But again, the placing, the being able to place microcalcifications inside enlarged ducts or microlobulations inside one of the other non-mass features increases the likelihood that it's truly malignant. So if we look at the PPV slope for echo pattern, and we say that 3 is just heterogeneous echo pattern, whereas 4 is heterogeneous internal echo pattern with specific microcalcifications, we can see that heterogeneous echo pattern alone has the PPV of a high 4B. 4B is greater than 10 and less than or equal to 50. But we can see that by specifically placing the calcifications inside of microlobulations, we get into that low 4C. So we get an approximately 22% pop in our PPV if we can actually place the microcalcifications inside of microlobulations or enlarged ducts. Now, if we look at peripheral zone and we look at the surrounding tissues, if we see enlarged ducts in the surrounding tissues without microcalcifications, again, it puts us in a high BI-RADS 4B PPV category. Whereas if we can actually show microcalcifications in the enlarged ducts in the surrounding tissues, it puts it in a high 4C. So we're talking almost a 50% improvement, or about a 50% improvement in the PPV, simply by proving these calcifications actually exist inside of enlarged ducts in the surrounding tissue. Now, people get the false idea on MR that there's vascularity inside the ducts with so-called DCIS. That's not true in the majority of cases. Most of this neovascularity is periductal or stromal. In fact, the only time we ever see vessels inside the lumen in so-called DCIS is when it's papillary DCIS, when the cancer develops in a pre-existing intraductal papillary lesion. So micropapillary DAB, no, nothing inside the ducts. Comedo solid, no. Cribriform, no, nothing inside the duct. Only when there's papillary DCIS do we see anything inside the duct. So here's a good case. This is a grade 2, mixture of grade 2 and grade 3 so-called DCIS, a DAB with neoducts. And what I'm showing you is the lumen has no vascularity in it. All this stuff we see around the lumen is periductal lymphocytic response, a little bit of desmoplasia, this thin pink layer, and then intense periductal lymphocytic response. And most of the neovascularity is in the periductal, and to a greater extent, notice the size of the vessels in the stromal. So it's a combination of stromal and periductal vascularity. There's nothing going on inside the lumen of this. Now, this is a grade 3 with tremendous periductal desmoplasia, the pink stuff around the duct, and tremendous periductal lymphocytic response. If I draw the neovessels in, if I highlight them with green and say they're abnormally leaky, that's where contrast is going to leak out. This shows how we get our ring enhancement. It's the abnormally leaky stromal and to a lesser extent periductal vessels that give us the clustered ring enhancement, or the Tram Trax if we're parallel to the long axis of the duct. So when we try to compare our NAME on MRI lexicon with non-mass ultrasound features, and we bridge them with histology, we get ductal or ductal branching pattern on ultrasound corresponding to linear branching on MR. These represent abnormal native ducts with or without branches. When we get we almost never see homogeneous texture on ultrasound, virtually always heterogeneous in these cases. But when we do get heterogeneous, we can actually see discrete microcalcifications, and I showed you the value of that on an earlier slide. So that's an advantage to ultrasound, actually. When we talk about microcalcifications, again, we can't see those in MR. So if these microcalcifications can specifically be placed inside one of the other non-mass features like microlobulation or enlarged ducts or neoducts, that really helps our positive predictive value. Now, kinetics gives MR an advantage. We don't have, Doppler is the closest ultrasound can come to MR kinetics, but Doppler is much less sensitive and really only good when positive. So I've come up with some thoughts on clumped versus clustered ring enhancement MR, and whether we're more likely to see clumped or clustered ring enhancement depends on, number one, the size of the structure causing the enhancement, AAB versus DAB. So in AAB, we have enlarged acini that are smaller. It's more likely to give us clumped. DAB with neoducts or involved native ducts, they're larger, they're more likely to have secretions or necrosis, and more likely to give us clustered ring. The size of the structure is affected by grade. So grade 1 and grade 2 tends to be enlarged acini or smaller neoducts, and that tends to give us more of a clumped pattern in MR. whereas grade 3 tends to give us larger acini with more necrosis in the lumen and more likely to give us clustered rings. Now, the luminal contents can affect it. If there's no necrosis or secretions, we're more likely to see clumped. If there's necrosis or secretions, we're more likely to see clustered ring. The spatial resolution of the MR makes a difference. If we have isotropic submillimeter voxels, we're far more likely to see clustered ring, whereas if we have autoplane resolution that's 2 or 3 millimeters, we're more likely to just see clumped. And in fact, sometimes we see that in the native acquisition plane, where the resolution is about 1 millimeter, we're going to see clustered rings, whereas in the reconstructed autoplane view, we're only going to see the clumped. And then finally, again, in-plane versus out-of-plane if we're not isotropic. So out-of-plane, that's 2 or 3 millimeters, going to give us clumped. In-plane, sub-millimeter, is going to give us clustered ring. Now, one of the things I've noticed is the default settings on MR tend to overbang the color. There's too much white, too much brightness, too much blooming, and it's hard to see the clustered rings. So many times, if you manually make the image darker and more contrasty, you can bring out clustered rings that you originally didn't appreciate. By the same token, we optimize our ultrasound to show the margin characteristics of a lesion, and many times the internal texture is too dark to really appreciate the internal as well as the external microlobulation. So I found on ultrasound, we sometimes have to intentionally overgain to bring out the internal microlobulation. So, I think that there's a definite advantage to using vacuum biopsy when you're trying to document the cause of non-mass enhancement on MRI with an ultrasound-guided biopsy. So basically, if it's just native ducts that are involved, it's really easy to shoot between the ducts with core biopsy and come up with a false negative. On the other hand, if you core biopsy into an area with neoducts, you're not gonna miss. At least some of your cores are going to bring up a positive study. So basically, I think that a combination of vacuum biopsy for the more centrally located thing where you might be shooting between the enlarged native ducts, and core biopsy for the more peripherally located neoducts might be the best combination for documenting the true extent of the disease on second look mapping ultrasound biopsies. Now I'm going to show you the flight simulator approach. And some of these cases are so extensive and so obvious and so easy that nobody could possibly miss them. And so you might say, why bother putting the probe on? I know the diagnosis ahead of time, but that's how you learn. You put your probe on the obvious cases, you figure out what you're seeing, and then you gradually move down to the intermediate cases and then to the difficult cases. So you start easy and you work your way down. So this case 1 is a large segmental distribution of clumped and clustered ring enhancement on MRI. It's going to show clustered abnormal acini ducts, neoducts, and or TDLUs with or without microcalcifications on ultrasound. And the bridging histology is going to show abnormal ducts or neoducts and TDLUs. So here's an area that's got a palpable developing segmental asymmetry. The calcifications are round, and if you just looked at the morphology of the calcifications, you might be falsely reassured. But anytime you have a developing segmental asymmetry, regardless of the morphology of the calcification, this is suspicious, and this in fact is very typical of the microcalcs in grade 3 micropapillary DAB, which this was. So here we can see the MR. We can see it's a segmental clumped enhancement, and actually some clustered rings too. I'll show you what changing the density can do for that. Here's the ultrasound. We're making an ultrasound sweep through this. And what I want to point out is that we have some larger, really weird, beaded, angular, changing in caliber central ducts. These are the native ducts that are involved with the micropapillary DAB. And then we have some smaller microlobulations that represent the neoducts around the periphery. So what we're seeing here is a mixture of native ducts involved. These are the large, big black ducts and smaller neoducts around the side. Now, when we do color Doppler, we can see that there's plenty of vascularity here, but absolutely none of this vascularity is inside the ducts. If I can slow this down a minute and we walk through this slowly, you can see that all the vessels we see are periductal or stromal. There's nothing inside these ducts. Only papillary DCISs can give us vessels inside the duct. Again, notice how large these central native ducts are with smaller, more solid appearing microducts. Now, here's the MRI. And what I've done is intentionally zoomed it. And now I'm going to make it contrast here. You can now see that we have several clustered rings as well as smaller clumps. So we have a mixture of clustered ring and clump. The clustered ring corresponds to the larger neoducts with secretions or necrosis, and the smaller clump corresponds to the neoducts, more around the periphery. So when I show this, we can see the larger fluid-filled ducts in histology. We can see the clumped neoducts around the periphery. So we've got a combination of spread through the native ducts and neoduct involvement. Okay, another case. Large segmental distribution, clustered ring enhancement on MR. We're going to see clustered abnormal neoducts with internal microlobulations and internal microcalcifications. And this is going to correspond to neoducts on MR. So here it is. It's grossly positive. It's BI-RADS 5. There's lots of pleomorphic calcifications, major asymmetry. Nobody's going to miss this. But look at how beautiful the MR is. It's a segmental area of enhancement with mixed washed-out pattern, narrow at the nipple, widening at the base. Again, if I enlarge this and increase the contrast, you can see they have a combination of clustered rings and clumped. And in this case, the clustered rings are correspond to the larger native ducts with more necrosis and calcifications, and the smaller clumped is going to correspond to the smaller neoducts without calcifications. Now, we start to see recurring patterns. I mean, these are two different cases, but they look almost like the other one. So we can see that we're getting a combination of clumped or clustered ring enhancement, segmental enhancement, narrow at the nipple, spreading out at the base. Okay, another case. Large segmental distribution, linear branching on MRI, abnormally large and morphologically abnormal branching native ducts, as well as clustered neoducts. And what we're going to have is a combination of native ducts that are abnormally enlarged and morphologically abnormal together with neoducts. So here we can see we're developing a segmental developing asymmetry. And we can see that it developed over 2 years. So 2 years ago it wasn't there at all. Maybe it was slightly there a year ago. Now it's a clear-cut segmental developing density. When we compress it, we can actually almost, if we have good imagination, see a branching, beaded, enlarged ductal pattern. MR shows a huge segmental asymmetry. It's a combination of linear branching and clumped. And closer to the nipple, we're seeing more large fluid-filled ducts that represent large native ducts that I'm showing in aqua. And the farther from the nipple we go, the larger the percentage of yellow neoducts and the smaller the percentage of enlarged native ducts that we're seeing. And so here's another histologic 3D correlation. We can see the larger ducts filled corresponding to the aqua-colored ducts representing enlarged native ducts, and smaller microlobulations representing neoducts around the periphery. So again, it's a mixture of spread through the native ducts and neoducts, with the neoducts predominating peripherally and the native ducts predominating centrally. Now, a really good thing to do if you want to convince yourself of the reality of neoduct genesis is to do split screen mirror image scanning on the two sides. So what I'm doing here is scanning at approximately the areolar margin on the normal side and on the abnormal side. And then I'm going to highlight the ducts. So the aqua ducts that I'm highlighting are the native ducts, and the yellow colored ducts are the neoducts. On the abnormal side on the left versus the normal side on the right. Notice how much more numerous they are on the side with DAB or neoduct genesis. Now, the farther I get from the nipple, the more pronounced the difference is going to be. And here we can see that these native ducts are about 5 times the size of normal ducts when I compare normal ducts on the right side to the largest central ducts I can see. It's about a 5 to 1 ratio. When I get farther peripherally, I'm seeing almost exclusively neoducts. They're not quite as enlarged, but much more numerous in terms of what I'm seeing in the native ducts. I only see 2 barely visible native ducts out this far, like 5 or 6 centimeters from the nipple, as compared to 20 or 30, dozens on the left side. And again, when I look at the size, the ratio here of the neoducts is more like 3 to 1 to normal ducts rather than the 5 to 1 that I was seeing in the native ducts. But I really like split screen mirror image scanning for documenting the concept of neoduct genesis. All right, here's another case. This is a smaller segmental area that's abnormal on MRI. We're seeing subareolar linear and branching and clumped enhancement on MR, and we're seeing abnormally large, morphologically abnormal branching native ducts with some neoducts as well. So here's the MRI, and I can see that I have Tram Trax on the subtraction. I can see I have Tram Trax enhancement. What is Tram Trax? That's exactly the same thing as clustered ring, only in this case we're parallel to the long axis duct, whereas when we get clustered ring, we're just going across the short axis of the duct. So these are Tram Trax periductal enhancement in a grade 3 DAB. Now, look at the size of these ducts. They're huge, and there's a lot of solid intraductal papillary lesion stuff within this. And furthermore, and here we're seeing a combination of Tram Trax, clustered ring, and clumped more peripherally. And what I want to show you here is that there's actually blood vessels inside the lumen of the duct. Again, we don't see this with micropapillary DAB. We don't see it with solid chemotonecrosis. We don't see it with cribriform. We only see this with papillary. So what we know is that there's either benign papillomas or there's papillary carcinoma in this duct in association with probable micropapillary. And this is something that Laszlo and I both believe is HPV related. So when we see a combination of papillary intraductal lesions together with what looks like micropapillary DAB, we think underlying HPV. Notice that there's clear-cut intraluminal vessels here, not at all typical of just micropapillary solid or cribriform. These are huge ducts. They're going to be 6 or 8 times normal size. Again, we're seeing a combination of micropapillary with solid papillary lesions. Sometimes they're benign papillomas and sometimes they're papillary carcinoma. Again, it suggests HPV. It's rather extensive. And we're looking at ratios of 6 to 1 to normal sized ducts. So these are grossly enlarged ducts. All right, another case, now we're getting a little smaller. This is focal, linear branching on MR. What we're going to see is abnormally large a branching native duct on ultrasound. So here's the linear branching on MRI. And in MR, we call them linear or linear branching, but on ultrasound, I can tell a duct from a non-duct. So if it looks like a duct, walks like a duct, and quacks like a duct, I'm going to call it a duct. But, we are trying to adapt ultrasound non-mass lexicon to a pre-existing MR non-mass lexicon. And so I might have to tone that down a little and say, yeah, we're trying to harmonize with a pre-existing MR lexicon. We're going to have to swallow our pride and call it linear or linear branching instead of ductal. And again, here's the enlarged duct on ultrasound. It's beaded, it's angular, it's irregular. The caliber varies, but it corresponds to exactly what we're seeing on the MR. Okay, now we're getting to a smaller, more subtle case. It's focal. It's clumped. What we're going to see is 3 enlarged TDLUs and the end of a duct. So it's probably a combination of AAB and a little DCIS component bridging 3 different TDLUs. So here's the area of clumped enhancement on MRI. It's got a fair amount of rapid washout, some plateau. We can see 3 TDLUs on the end of a distal duct on ultrasound. Each of these is an AAB. So in there are enlarged acini, but we can't actually resolve them individually on ultrasound. Certainly larger than normal ducts by several folds. And this is a simulation, or not simulation, but a matching histology that you might see from a Tabar 3D slide. 3 TDLUs on the distal end of a duct with some bridging DCIS. 1, 2, 3. All right, and that was a grade 2 multifocal AAB with a little grade 2 DCIS bridging them. So again, the fact that it was grade 1 or grade 2 favors that it started in the acini of the TDLU and then spread. So this is a more subtle, smaller case. We got focal distribution. We have clumped enhancement. And we have a single enlarged TDLU where each of these little enlarged acini within it is contributing to it. We can see that in MRI, it looks clumped. Even when I make it more contrasty, I can't show any clustered ring because these are enlarged acini and they're probably only in the 5 to 8 millimeter size range, too small for us to see a clustered ring. And on the Tabar slide, you can see how we could get this appearance. This is a single enlarged TDLU with a highly variable size in the enlarged acini, some having necrosis, some not. Now, one of the things about this is that if you wait, if you do 4 or 5 different images at different times, the contrast kind of spreads out over time. So you really have to look at the early post-contrast in order to see the clumped enhancement. Because as the contrast spreads over time, the contrast is going to spread out and it's going to start to become more homogeneous and looking more like a mass. So to really tell mass from very subtle non-mass clumped enhancement, it's important to look at early phase before the contrast is diffused out and prevents your ability to do it. So this is another case. This was a screening MR. We have two different things, a small mass and a very tiny focus of non-mass enhancement that's occurring in clustered microcysts. Here we can see the screening MR. We got a tiny little mass posteriorly and a larger area of non-mass enhancement anteriorly. When I look at the pre-contrast non-water suppressed, we can clearly see that they're clustered microcysts corresponding to the anterior non-mass enhancement. And when there's contrast and we subtract, we can see most of the enhancement is along the superior end of these clustered microcysts. Now the smaller, more discrete posterior mass has entirely rapid washout, and this was a small luminal a grade 2 invasive cancer, but we have mostly plateau washout in the clustered microcysts. So this was the second look ultrasound on the smaller posterior mass. We can see it looks like a single enlarged posterior TDLU, invasive AAB, and in effect that's what it was, luminal A. But the anterior non-mass enhancement, we can see these enlarged, clustered fluid fill containing neoducts with some suspended microcalcifications. Remember that the calcifications we tend to see in Abergen metaplasia tend to be milk of calcium or calcium oxalate. They tend to follow the bottom. So the fact that we have suspended microcalcifications and a complex cystic and solid is concerning. And then when we turn on color Doppler, we can actually see that the area of abnormal Doppler flow along the superior end of the clustered little neoducts corresponds to the plateau washout that we saw in MR. So this turned out to be a micropapillary DAB. This is one of the smaller micropapillary DABs we've seen. It was grade 2 rather than the usual grade 3. And generally when we see micropapillary DAB, it's neoducts, it's a stem cell duct-forming invasive cancer, and it's usually big. I think the only reason this looks small is it probably developed in a smaller lobe. So we discussed how there's different success rates for second-look ultrasound when there's mass on MRI versus non-mass enhancement on MRI. We discussed how the lack of a non-mass lexicon for ultrasound sets us up for going in the room and looking for a mass when we should not be looking for a mass, and that if we had a proper non-mass lexicon for ultrasound to give us a better idea what we're really looking for when we go in the room. We went through a series of correlations about how this correlates with AAB, DAB, native ducts, neoducts, the various types of spread, the various relative sizes of the ducts, and how split-screen mirror image scanning can help us show too numerous ducts. And we showed you a spectrum from grossly obvious giant lesions that nobody could miss down to really quite subtle small lesions, and how that learning process can help you learn how to detect non-mass findings on ultrasound that correspond to non-mass enhancement in MR. So in conclusion, I think the DeBar classification system really could help radiologists to better understand what they're seeing on second-look ultrasound when there's non-mass enhancement MR. And the MR lexicon existed first, so if we're going to quote-unquote harmonize ultrasound non-mass features with MR non-mass features, we in ultrasound are going to have to flex to match the lexicon. So even though I made a big stink about how I can tell a duct from a non-duct, if we're going to harmonize with MR, which uses linear versus non-linear, we might have to use that terminology for ultrasound as well. And hopefully this has been helpful for you. Thank you.